I wanted to introduce myself. So Barbara Wirostko. I'm actually just finishing up my clinic myself. And the reason you're here today is basically to learn a little bit about what I'm hoping is going to be really instructional in terms of the IOP monitoring and remote monitoring at home. And really what I've been learning from it and why I've become so passionate that this really should become more standard of care for our patients. It's really analogous to using a continuous glucose monitor or even an intermittent glucose monitor, and you're trying to figure out, those glucose spikes. And I just want to say a special hello to Joa because he was my resident back in the day at Moran. So great to see you here, Joa. So Barbara Wirostko.
Here.
Thanks, Joa. I'm an adjunct professor in ophthalmology and biomedical engineering and a glaucoma specialist. And I really got introduced with the eye care home when a patient of mine realized that he had been treated for over 20 years for normal tension glaucoma, was continuing to learn to lose vision, and actually was not being controlled. And he was spiking early in the morning and he was on max medication. So it really changed his course. Next slide. So these are my disclosures. I do consult for eye care, and I am one of the co-founders for MyEyes because I was passionate about trying to get this device in the hands of patients. Next slide. So we all know about glaucoma, slowly progressive optic neuropathy, and we really rely on a number. How often do we ask our patients, what was your maximum IOP? And we look through past records and we look at our records and what was that highest IOP? And we lower pressure based on that maximum number. But what about if we're not really finding that maximum number, really not using the correct number? How does that really change our treatment patterns? Next slide. So we also rely on IOP as it's the only modifiable risk factor. Of course, we're really interested in neuroprotective agents. I have patients that use nicotinamide. I'm very interested in perfusion, blood pressure changes, but at the end of the day, we treat based on a number. And clinical studies have shown that if we lower that number, we can slow down progression, right? In our practice patterns. But even in our practice patterns, it discusses diurnal IOP. And really, up till now, we never had a good way to actually measure diurnal IOP, right? Back when I was a resident, we would admit patients. And as a resident, I was the one waking up the patient in the middle of the night to check the pressure. But we really don't have an easy, accessible way where a patient can actually look at their fluctuations and measure that and then provide that input to us. And again, we go back to the fact that we diagnose and manage by identifying that highest or maximum IOP. Next slide. So some interesting literature, when you look at what's been published and you go back to our progressive prospective studies, the studies have shown that, in fact, IOP fluctuation actually also leads to progression. Sanjay Asrani has done a lot of work with normal tension, and he actually believes that if a patient fluctuates more than 3 millimeters, that's actually also linked to progression. So, I mean, I think about my patients who come in who are fluctuating between, say, 15 and 18 or 18 and 21. He would say that patient's not controlled. The most interesting paper, I think, is the SIGITS paper. That's the one in the middle by David Mush. And that looked at IOP fluctuation over and progression over 9 years. So what they found was that independent of where that baseline IOP was when the patient entered the study, if a patient was having more than 8.5 millimeters delta change, that was directly correlated with visual field progression. So again, remember that number, 8.5, because you're going to see some indications in some patients that are actually fluctuating from 12 to 20. And even though they're normal, that amount of IOP change could actually be causing damage and progression. Next slide. So a little bit about diurnal and nocturnal fluctuation. We know blood pressure fluctuates. We know that glucose fluctuates, and even if IOP, it fluctuates with position, with sleeping, time of day, cortisol levels, nitric oxide levels, exercise, water volume, water drinking test, right? You can make IOP fluctuate. We also think, we know that if you're looking at an IOP at a single time point every 3 to 4 months, that's a matter of seconds, but there's 31 million seconds in a year. So you're really just getting a snapshot. And we also know too that even patients with normal, and I don't even refer to my patients as true normal anymore. What is a normal pressure? But we do know that patients continue to progress even if their pressures appear to be controlled. And I go back to the fact that we know that outcomes are better if we monitor blood pressure. We have patients do halters. We have them monitor their blood pressure after exercise. And we also know that glucose as well. Diabetes is better managed if we know the fluctuation. So we have all these other physiologic parameters that fluctuate, and we look at change over time. And yet here in glaucoma, as an ophthalmologist, I'm waiting for damage before I make a change. And that just, I almost look at it as akin to a diabetic. You're not going to not treat a high glucose number, and say, oh, we're not going to treat your glucose number unless you lose a limb. Then I'll intervene. And are we not doing this with glaucoma? Are we not saying, oh, now that you have damage, now I'm going to treat? Next slide. This is a really interesting paper, and this was actually done in 1973, and this was an endocrinologist who knew that cortisol or something in the blood actually could be impacting IOP. So he had 11 patients come in. He kept them overnight in a sleep lab, and he actually measured cortisol levels systemically every 20 minutes, and he measured IOP every hour. And I think this is fascinating because, again, this was the 1970s by an endocrinologist, and he saw that the cortisol levels spiked first upon those early waking hours, and then the IOP went up. So it made him conclude that there was something in the blood, hormone, substance, pH, blood pressure, but they were affecting the circadian rhythm of an IOP. Next slide. And this was over 50 years ago. We also know that not all glaucoma treatments are effective. We know that prostaglandins and carbonic anhydrase inhibitors work better in some patients. They also work better during sleep. We know that beta blockers traditionally do not work during the night, which is why they tend to be very effective as a once a day in the morning. And we also know that different surgical measures can be more or less effective on lowering IOP. So can we determine if a therapy is effective before we're losing visual field, before we're having damage? Next slide. We know that rebound tonometry works. We've had rebound tonometry around now for over 20 years, and it's been used in the animal world and veterinarian space, and even with the FDA for years. And we now use it in our office. And there's been numerous studies, and there was just a question that came up from someone who had registered. So how were these instruments actually validated? So they were validated looking at Goldman, looking at the Eye Care 100, as well as the Eye Care Home. And they were looked to validate sensitivity, specificity, both in normal healthy individuals, normal tension glaucoma, and then also POAG. So there were numerous studies starting in 2016 that actually worked to validate this technology and compare it to the gold standard. What's nice about the Eye Care Home is it's not as reliant on a corneal thickness on a CCT. But at the extremes, so at a low pressure, the eye care home can actually underestimate. So a pressure of 10 on GAT, you may get an 8 on the eye care home. And on the other extreme, the eye care home may actually overestimate by 2. But generally, it's pretty similar. It's about a +1 to +2 within that sort of normalish range of IOP. Next slide. But hundreds of patients. This has been validated with hundreds of patients. The other thing that we liked about the eye care home is that it's easy to use. The clinical studies have validated it's reliable, it doesn't use anesthetic, and the data uploads to the cloud for the patient. Next slide. So where does the data come from? So this is work we've been partnering now with Moran and Harvard and Wilmer. And specifically Wilmer and Moran, we have an IRB that's open looking at patients using the eye care home and trying to identify who is spiking and what time of day are they spiking and how many days should you use the eye care home. So Tom Johnson and Elise McGlunkley did this study. It was 107 eyes. And essentially what they found was that maximum IOP was occurring between 4:30 a.m. and 8 a.m. on 24% of the days. The other thing that was crazy was the mean daily maximum IOP exceeded the clinic IOP in almost 50% of these patients. And they were generally younger men, and obviously hadn't had surgery. But they concluded that self-tonometry may provide useful information, especially in those early waking hours. And this really is what we've been recommending to our patients, is to use the eye care home in those early waking hours. Set your alarm. If you wake up at 8, set your alarm for 6 and see if there's a spike. Next slide. And this is some of the data that they found. So this is one particular patient. This was published in Ophthalmology Glaucoma in 2021. And the patient had reproducible elevation, and you can see over the span of a week, every morning, early waking hours between 6 and 7 a.m. And then by time they would come into the office, they would be dropping down into the teens. So their fluctuation was anywhere between 17 and 28. That far exceeds that 8.5 millimeter delta that the SIGIT study showed actually could be linked to progression. Next slide. The other next thing that we did was our group, again, between Wilmer and Moran, started to look at some of our patients. And we said, could home monitoring actually help figure out pre and post-treatment patterns? So what's the effect of some of the interventions? And is it doing anything to this fluctuation? Next slide. This is a really interesting patient as well. So this was a study that was done out of Iowa. So this was Cy Maroy's fellow, I believe, Rojas, again, published in Ophthalmology Glaucoma. And this was a surgeon. So this was a surgeon who was on medical therapy. And you have his right eye on top, his left eye on the bottom. And every time he would come into the office, he was generally in the teens. So he had exfoliation. We've been finding exfoliation patients spike to a much greater degree and in the early waking hours. So he was actually spiking to 43 in his right eye. And again, you can look at this chart. If you look at those other numbers, by the time he would get into the office, he would be in the teens. Interestingly enough, what they did is they changed him, they took him off his Vyzulta, kept him on his bromonidine, and then put him on Notarsidil. So is there a role of perhaps episcleral venous pressure being elevated here in the early waking hours? But I thought this was really quite dramatic, because how often when our patients are showing continuous damage or progression and their pressures are controlled in the office, do we think, oh, maybe they're just not using their eye drops? I would bet he was using his eye drops. And he clearly was spiking, which probably was most likely damaging his optic nerve. Next slide. Information on SLT. So here is a great example of where I use the eye care home to actually help me determine whether or not I should treat a patient. So this is a woman of mine. She's a 76-year-old female. She had unilateral exfoliation in her left eye. And every time I would see her, she would have a normal IOP. So her right eye would be 16, left eye 18. Her left eye was always 2 millimeters more in clinic during normal clinic hours. So 17, 19, 16, 18. Maybe she had a little OCT thinning on that left eye. Visual fields were full. She was a myope, so maybe that was why her OCT was a little thinned. And we kept debating whether or not to treat her, but she was normal. Well, it turned out that on the eye care home, that left eye was actually spiking, as you can see, close to 30, and definitely into the mid to high 20s on a regular basis. So that's the red line there. The blue line is her right eye. We did an SLT, and what it did was it flattened that spike, it flattened that curve, and it superimposed that left IOP almost on top of the right. So it brought it down to probably what is her normal physiologic variability. There's going to be fluctuation, but what's normal, I should say, for a patient, and that we don't yet know. Next slide. Hopefully I intervened early, so hopefully we're going to hold off on some damage. This was another case that was very interesting. This was a case out of Wilmer. Jitham Johanna gave me the information. He published this in 2022. This was a 37-year-old man with uveitic glaucoma who was complaining of intermittent headaches. In the office, his IOPs were the high teens to low 20s. But yet when they did the eye care home, he was actually fluctuating into the 40s. So they did a goniotomy. They did a gap. Next slide. And this is what happened to his IOP. So it's interesting. I mean, here you see a lot of variability. He obviously had a lot of resistance at the trabecular meshwork. And by doing a goniotomy, they must have just reduced that resistance, and there was nothing distal to the trabecular meshwork that was offering the resistance, and they were able to flatten those IOPs just with a surgical intervention. So again, it makes me wonder, was the uveitic glaucoma and the steroids actually responsible for those changes in the trabecular meshwork? Perhaps. Next slide. Last case that I think is going to be, again, another interesting case. So information, right? Basically giving that patient ownership, empowerment, control, and reducing a lot of anxiety. So this was a patient of mine at Moran. He was used to be the head of cardiology. He was an 84-year-old cardiologist. Again, another exfoliation. There seems to be a theme here, right? The exfoliation. But he had surgery in his right eye by one of my colleagues, excellent surgeon, and he had a very complicated cataract procedure. He had IOP spikes into the 50s. He was a steroid responder. He then developed a herpetic uveitic picture. He developed corneal edema, bullous keratopathy. And he ended up with count fingers vision in that right eye. His left eye cataract was getting worse. He was 20/60. His pressures were 24 and 14. He had a really thick cornea in that right eye. And he was on a prostaglandin and co-sopped. He was very worried about having his cataract surgery in his left eye, because what happened in the right was when he was having those post-operative spikes, they were immediate post-operatively. He was running in the 30s to 40s. But he wasn't in the office and he wasn't coming in. So he didn't know. Nobody knew that he was having those spikes until he showed up in the office a week later. A week later. His nerve in that left eye was healthy. Next slide. And this is what his OCT looked like. So nerve was was healthy on the left, but he was really worried that if he underwent, and he had some exfoliation in that left eye, but it was not glaucomatous yet. But he was really worried that if he underwent a cataract procedure in that left eye, how would he know that his pressure was spiking? So my colleague, Dr. Chaya, told him about the eye care home. He wanted to use it. And you can see on the right hand his eye care home data. So his right eye is spiking. He has account fingers. We needed to address that. But his left eye was also spiking, was spiking into the 20s. And then what we were able to do was we pre-treated him. We did put him on some Diamox. And then post-operatively, because he had the eye care home, he was actually able to monitor his pressure. He also got an ABIC hydrus in that left eye, and then Dextenza for the inflammation. But the empowerment, the ability to know that he would be able to identify a pressure spike if it was occurring, and hopefully prevent the vision loss that he had undergone in the right eye, really gave him the confidence and the comfort to say, let's go ahead with the procedure. And he's at 20/20. He's a minus 150. He's very happy, and his pressure's 13 just on COSOPT alone. Next slide. So what I have found useful is twofold. I've used it as a diagnostic tool. I've used the eye care home for a week to figure out if a patient's spiking, if there's something that I should be doing differently to try to manage or identify those IOPs. Obviously, the first or the most obvious, right, is a patient with normal IOP that's progressing. But I think even patients show up in my office who are on 4 or 5, 2 or 3 medications, and I'm trying to figure out what's the next management step. This has been really, really helpful. I look at it differently. If a patient is spiking to the high 20s, my management's going to be very different than if their highest IOP is 15. And a lot of it is just flattening those spikes. The other thing too is a monitoring tool. And I think this is where it really comes down to glaucoma is a chronic disease. It doesn't go away. Drops can fail. Sustained release can stop working. Surgeries can fail. And how do we really know when our therapies that we're using wax and wane and stop being effective? It's a bit of a guesstimate. We say, oh, everything looks good, come back in 3 months. I had one patient who owns the eye care home, and they were able to tell me that their pressures were creeping up, and it was at the time that the Zen was scarring. And I thought they were kind of, home clear. I thought, the Zen was working, things were fine. But no, the Zen was now scarring and their pressures were creeping up. And I was able to get them back in the office faster and get them back on therapy and change their management. So again, as a monitoring tool for patients. Next slide. So in summary, I think there's a lot of value to be able to detect these IOP spikes, especially the fluctuation, the variability. I think it gives us real world data that's actionable. Patients, again, feel very empowered. One of the questions we get, and Eric is going to talk about it, is will patients call you in the middle of the night? I have not found that to be the case. And we now have, several thousands of patients who have used the eye care home and or own it. And it's not, they can understand their disease. They are now empowered. They're taking part. They're part of the solution. And it gives them, I think it actually reduces anxiety. Can some patients have more anxiety? Absolutely. Think about your patients. But it really does improve compliance because they see the results. I have also had patients come to me and say, oh, I was using the eye care home and I noticed that I forgot my eye drops, or I ran out and my pressure was creeping back up. Wow, my eye drops really work. So again, it's evidence to them that what you're doing is working. So I found it really helpful. And then again, I really stress that those early waking hours could be when these pressures are going up. Lou Pasquale is a firm believer that it could be related to lower nitric oxide levels. You know, when you think about it, it's also the time of day when patients tend to have ischemic optic neuropathies or strokes or heart attacks. So what is going on with the cortisol and the vascular system? I think that also could be playing a role. So we don't know those answers yet. There's a lot we could be learning. Next slide. And of course, this is not, you know, done in a vacuum. This is a huge undertaking with a lot of my colleagues across the country and a lot of learnings. And there's a lot of people that are very excited because it's really opening our eyes to how we could be better managing our patients. Next slide. So with that, I'm going to turn it over to Erica. So Erica actually met us because she was originally a patient using the eye care home. She's also a registered pharmacist, and she is our vice president of patient success. So, Erica?
Thank you, Dr. Wirostko. I appreciate that. Next slide. So like Dr. Wirostko said, I am the Vice President of Patient Success here at MyEyes, and we rent and sell home tonometers. So some of you have used our services, some of you have not for your patients. But I'd like to tell you how our service works for patients. I think there is a little bit of confusion sometimes about how using MyEyes or using the home to for your patients integrates with how you use it in your practice, and you know what the expectations are of the patient, what the expectations are of the practice. So I'm going to walk you through how we do it at MyEyes. And as Dr. Wirostko said, I am a patient, and I'll get into kind of my story in a little bit and tell you how I stumbled upon MyEyes. Thankfully, I did. But really, what happens is the patient places an order on the MyEyes website, and or the physician places a prescription order. So one of those two things happens. We find that some patients are very proactive and they want to use, they've heard about home tonometry, they want to use it, and they go to their doctor and discuss it. Other times we have doctors that will, you know, prescribe it for their patients on a regular basis. They put in the prescription. Either way, that's what starts the process, or the patient calls us, they'll talk to us. Our patient ambassadors are amazing. They're also glaucoma patients. So we're basically a team of glaucoma patients and glaucoma professionals that, comprise MyEyes. And once that happens, we walk the patient through any questions they may have, whether it's about insurance, and I'll get into that in a minute, whether it's about cost, whether it's about, can I use this? What's it all about? And they have a host of different questions. And again, we're talking to them, glaucoma patient to glaucoma patient. So it really, I've found it really puts their mind at ease right away that, you know, they're not just talking to somebody who, you know, is a salesperson or anything like that. We're actual patients. And we use the home to manage our disease on a daily basis and manage with our doctors. Once the order is placed and once we have the prescription, MyEyes will ship the home to the patient within 24 hours. A lot of times it's the same day, and it's usually 2-day shipping. So from the moment that patient places the order, they have the device in their hand, usually within 2 days. And we can space that out however the patient needs it. If they're going on vacation, they want to do it here, they're having a procedure, they want to do it 2 weeks before. We're super versatile about how the patient needs to use that device and the timing of it, because we all know that that's really, really critical, especially if you're looking at therapy change or doing some type of procedure. So once the patient gets the device in their hand, they get a call from one of our patient ambassadors. They also get a call when we get the prescription as well. So we know them by this time. So by the time we call to get them set up with their home too, we've already talked to them. And so we set them up, we walk them through, setting up the device, if they choose to use the app. If not, for those of you who are not familiar, the Home 2 does not display the result on the device. You have to download an app to a smartphone. We do have doctors who do not want their patient to see the number, and that's fine. We can do that as well. And there are patients that don't want to bother with the app. They just want to take their measurements, download them, take their measurements, send the machine back to us. We download them, and then we send the results. So we're really flexible in that sense that, we're sensitive to the fact that there are some patients who really want to see their numbers and some that don't, and maybe some that should, and maybe some that shouldn't. So we really try to respect the doctors and the patient's input with that, so they have a choice. Once we onboard them, we follow them, like we're check in with them. Hey, how's it going? If they are using our eye care clinic, then we can go in and look and see, is Mrs. Smith using her device? Okay, she only took 2 measurements 2 days ago. We need to check back in with her. So we follow them throughout a rental. If they purchase a device, we're here for them throughout the entirety of their home tonometry journey, and we can help them through the process, the troubleshooting. If they have any issues at all, we're here for them. So once they're done, if it's a rental and a patient can rent for 1 week, multiple weeks, and I'll get into the options that we have toward the end. But once their rental is done, they pack up their device, they put it in a box, they attach the label that we've sent to them, and they send it back to MyEyes. From there, we download any data. Even if they've downloaded the data to clinic, we make sure that everything is downloaded that was in the machine. And from there, we send a report to the patient, and we send a report to the physician's office. And the nice thing is we have some offices that the doctor wants the report, and we have some offices that it goes to a tech. The tech then uploads it. It comes in a PDF format, and I'll show you that in a second. But we're here basically Monday through Friday, 9 a.m. to 7 p.m. Eastern. And again, I'll talk about health insurance reimbursement in a second. But the bottom line is if you write a prescription for a patient, you're not going to hear from that patient or from us until that patient has completed their rental. They send the machine back to us, and patient's been taken care of through the whole journey. And then you get the results after that. Next slide, please. So just to give you a little bit of information about our service, we've had a solid customer service department here for the last 2.5 to 3 years. And over that time, we have a customer service satisfaction rating of 95%. From there, we have a 98% success rate, meaning 98% of our patients actually can use the device, take measurements for a period of at least a couple days, a few days, and take regular measurements, which is pretty outstanding. I'll talk a little bit later about the myth of, maybe my patient can't use this, or it's too complicated for, people who are advanced aged. We walk them through it. Our patient ambassadors are, again, champions for these patients to make sure that they can get a reading and they can use the device. We answer 96% of our inbound calls are answered live. You can look at some of the other stats there. We have a live chat as well, so patients can reach out that way. They can reach out by email. We have a 95% customer service rating for our chats as well. And then you can see some of the institutions that we partner with, and that's just a small snapshot of who we partner with now. We get new doctors every single month, and it's exciting to see, especially for a glaucoma patient like me, because the word is catching on, and more and more doctors are using home tonometry, and once you've experienced it as a patient, you really, really understand the value. Next slide. So again, how does MyEyes help you and your team? We help you through time efficiency. We handle the service part. We ensure that the patient does not expect you or your team to train them or manage them through this process. We take care of everything from beginning to end. We even will call, if a patient wants a prescription, we'll call the doctor's office and get a prescription for them if they need it. Customer service, I just talked about that. We are a team of glaucoma patients, caring, compassionate, and we manage our own disease with a home too on a day-to-day basis. And then the quality IOP data that Dr. Wirostko talked about, it's invaluable. I'll show you some of the reports and the reports that you will get as a physician. And each one tells a story. I happen to be the person right now who downloads the patient report and sends it. And each one, it's a story. So you see the chart and you're like, whoa, like that, like if you know what you're looking at, you're like that patient's really fluctuating, that patient's really spiking. And again, we're not in it to talk to the patient about that, but it's amazing to me to see those reports, and everybody's different. It's like a fingerprint, right? Your IOP fingerprint, basically. So next slide. So some myths about home tonometry and prescribing. And Dr. Wirostko talked about the first one. My team will get calls from patients for setup and support, and they don't. I mean, for the most part, again, we all have, we all know patients that are very needy or just need some extra time and attention, but we really strive to make sure that we are taking care of the patient from beginning to end, and that your team, your techs, don't have to even think about it once you've written that prescription. The patients will call after hours if their pressure seems high. Again, that's not the case. That's not been my experience. Again, I've been here for almost 3 years, and we don't have that. There have been instances where we may notice that a patient is spiking above 50. We'll give the doctor's office a heads up if that's the case. But usually, if the patient is that high risk, a lot of times the physician will reach out to us mid-rental and be like, hey, how is Mrs. Smith doing? And can I have her results so far? And then decide, do I need to extend it for another week and just track her for another week? So, most of the docs are working very closely with their patients to begin with, especially a patient that you're doing home tonometry with. The next myth, and this is a tough one. So my patient won't want to pay $250 to rent a device. And I have to say this was me, because to give you a little bit of my background, I have ICE syndrome. So I have secondary glaucoma in one eye, and was diagnosed probably about 12 years ago, and uncontrolled glaucoma, had an OMID implant, and was fine for like 8 years. No problems, no issues, none that I know of, because I was just getting checked in the office, but there were no issues. And then in the office, my pressure started creeping up, low 20s, which for me wasn't terrible. So because of the rarity of ICE syndrome, my glaucoma specialist was like, well, I'm going to send you to pretty much every specialist that I know, so we can all make an informed decision and figure it out. There's not many studies with ICE syndrome, so it's kind of hard to know what the next steps are. One of them said, you need to rent this home tonometer. I'm like, I didn't even know what that was. Again, I'd been stable for many years. I didn't even really give it a thought. I took my drops. And so I rented it and was like, oh, $250, that seems like a lot. I have 3 little kids, and so I rented it, and we found that my pressure was spiking regularly into the 40s late at night and first thing in the morning. So needless to say, what we thought we had a few months to figure out, I had surgery about 2 weeks later and got a Bayerfeld implant. So, but from there, I remember, and I say this to people all the time, when I had the tonometer and I had it at home, and I was like, this is incredible. Like, I can check my IOP anytime I want. And this is just in 1 week. And sending it back to MyEyes was like saying goodbye to a friend. Like, it was hard to let it go. But then I'm like, you know what? I should buy one of these. It's really expensive. Insurance doesn't pay for it. My kids have activities. but I ended up purchasing one, and it was critical when I got the Bearvel implant, as you know, because it takes time to open, and was able to literally pinpoint the 24-hour period where it started working. So really incredible to be able to use that. And I can tell you after that, that was 3 years ago, almost 3 years ago, the device has saved my vision on multiple occasions since then. And it's allowed me to, if I feel there's an issue with my eye, or there's something that doesn't feel right, whatever, I see my pressures creeping up, that's something that my doctor and I can address right away. And it doesn't go months or weeks without being checked and without being unchecked or even unknown, right? So if you're spiking in the 40s at 3 o'clock in the morning, you're not going to know that at 2 o'clock when you have your doctor's appointment. So I have to say, from an empowerment level, it's incredible. And any of our patients that you talk to will all say the same thing. Anybody who owns it, anybody who's used it, it's very, very empowering for us. So next slide, please.
Erica,
Go ahead.
maybe share too, because I thought it was so interesting, not interesting, that's a bad word, but it was insightful remember when you had that episode and your vision was blurry and you called me and you're like, I'm wondering if my pressure's fluctuating because you were worried, if it was your cornea.
Yes. So it is interesting with ICE syndrome. You've got the cornea component, you've got the glaucoma component, and then you've got a host of other fun things. So my vision was super blurry. I'm like, okay, first thing I check is my pressure. So I started to check my pressure 2 or 3 days. I'm like, it's fine. And with the Bearvel, it's low. I'm under 10, which is just huge. So, I checked it, it was fine. I'm like, okay, it must be cornea related. So I start doing, the drops and the ointment for the cornea swelling and things like that. That didn't help. Again, in the meantime, I called Dr. Wirostko, and so that didn't clear it up. But then I was able to, she's like, I think you need to go in and be seen. So I saw my glaucoma specialist. I had macular edema, like an acute case, which is kind of turned into a chronic case. But at the same time, it allowed us to identify that within a matter of a week. Whereas if I didn't have that, this would have gone on for a period of time and been a lot worse than it is. And even now, I now get Ozurdex drops, or I've been on steroids for the CME. I've been on a host of different steroids. I'm not a responder, thankfully, but I'm able to monitor that throughout any type of treatment that I've had. And the Ozurdex, the same way, I'm able to monitor the minute I feel. I'm probably not as compliant as I could be. I don't take it every day, but I know when I need to. And you start to learn that, and you start to understand, when you need to take your pressures and when you don't. And, again, I had a glaucoma specialist appointment the other day, and I was 20 in the office, and that was way more than I've been. So that was a red flag to come home and start testing for the next few days. And it was a fluke for whatever reason. I was 20 in the office, but I was fine after that. But it's that peace of mind that I don't have to be 20 in the office and then go for 3 weeks, which is probably when I would have had to come back, because that's high for me now. And have that anxiety about, oh my gosh, what's the next step? I've got 2 tubes in there now. Like, what do we get? So it just takes that all away, and it's super, super empowering. So thank you for reminding me of that, Dr. Roscoe. So my elderly patients will not be able to use the device. I can tell you that our maximum patient age is 102. So she used it. She had a helper. She had her daughter help her. And a lot of our elderly patients do have helpers, which is great, or an aide or somebody, or usually a grandchild that can help them with the app if they use the app. But the bottom line is again, 98% of these patients can use it. And our average patient age for a rental is 70 years old. It's a little bit less for a purchaser. But again, that's a myth, because they can use it. I would say if somebody has severe Parkinson's or tremors, things like that, it's definitely trickier. It's definitely not for everybody, but the the majority of patients that we see can use it. Some patients do get anxious when they hear that there's a probe that touches your eye, and they're fine. And then they get the device and then they're like, oh my goodness, that really does touch your eye. So, I mean, again, some of that's just education and explaining it to them and walking them through it and just supporting them through it. And generally it's fine. But again, if you have a patient who's super anxious like that, it may not be the right choice for that patient. So how do patients use the Home2 once they are stable? I talked about that. Again, I use it regularly to check for spikes and fluctuations. We have patients that we have some really interesting patients. A lot of them that travel. We have patients that are in really remote areas, and so they're able to check their IOP remotely. We just had a patient a couple of weeks ago who is a few hours from her glaucoma specialist. They were able to, through the Home2, be able to adjust her meds without her ever having to go into the office, which is really incredible. We have a deep free diver. We have hikers. We have an extreme hiker. She's actually doing Everest Base Camp, and she's going to take her Home2 with her in November. So we have people that do a lot of extreme things. Again, they may be on the younger side of our patient population, but it's, again, just knowing we have patients that are just so involved in their disease and wanting to find out what makes my IOP fluctuate. And they bring that information back to us, which is also just such a gift. Next slide. So prescribing. Prescribing is easy. I just wanted to touch on this. Again, many of you have already prescribed, but basically you go onto the myeyes.net website, and there's a button that for prescribers, and you click the button, you go in. If you're a repeat prescriber, you just put in your NPI number and the patient information, and you're good to go. We do ask for the diagnosis code now because that really does help with the patient getting reimbursed by their insurance. Or you can submit a prescription just online, send a picture. The patient sends a picture sometimes. Either way, whatever's easiest for you in your practice. It's the same information that you would need on a regular prescription: patient name, date of birth, phone number, your information, and even your NPI. Like we can get that information from there. So we try to make it super easy for you to submit your prescription. Once you do, it's good for a year, just like other prescriptions. So if a patient is a renter, they decide to purchase, you don't have to write another prescription. We just go with what we've got on file. Next slide. The reports. This is my favorite part. So you can see in the reports, and Dr. Wirostko already showed you some of these. And this is one that came in, and you can just see, right off the bat, you see this picture of a patient who's got these huge fluctuations in one eye over the other. And you have to wonder if there was some intervention there in the middle. So the reports are sent in PDF format. We send them to the doctor's office when the patient's rental is done. If it's a purchase patient, we're happy to send the results along the way. Most of our purchase patients download the information themselves. They have access to these reports, so they download it themselves and take it to their doctor's office. You get the whole table underneath, which is usually a few pages long, so I didn't include that here. But then from there, if you want a tech in your office to upload the chart, we can send it to the tech. You can add other email addresses that we send it to, and generally they upload those to the patient's chart. MyEyes, it's super exciting, is working with Harvard and Johns Hopkins on Epic integration software. So that's something that's in the works right now, and hopefully soon we'll be able to just send that report directly to the patient's chart for those that use Epic. Next slide. So along with the IOP report, I just wanted to show this. These are the other two that we send. This is the right eye, the diurnal curve, and the next slide is the left eye, diurnal curve. And those are the three reports that we generally send with any patient. And again, it tells a story. So you can look at any one of those and say, okay, I can see what Mrs. Smith is doing. And this is where I may want to intervene. Maybe I change the time of day of her drops, or maybe it is time to do some other kind of, invasive type of therapy. But it tells a story. So insurance coverage. I think this is a big sticking point from the physicians that I've talked to. It's tough to ask somebody to pay $250 for a medical device to rent for a week. And some patients flat out can't afford to pay that. But we have at MyEyes, I would call it a grassroots effort to try to get this covered by insurance. And when I first came on, at the very beginning of 2023, the answer was no. Like if somebody said, is this covered by my insurance? No. So over time, we realized that there were certain patients that were just tenacious, and they just go after it, and they would submit the claim, they go back, they'd get denied, they'd appeal, and go back and forth. And then lo and behold, some of these patients were getting reimbursed partially, fully, for rental or a purchase. So that was a huge light bulb moment for us, where we're like, you know what, we're going to help the patients get reimbursed. We do not bill ourselves, but when a patient purchases or rents from MyEyes, we give them everything they need to submit a claim after the fact. And we're actually getting some patients. We had one just a week ago who got approved for a prior authorization for a machine. So that's huge. Like that's not happened before. So Medicare at this point does not reimburse. We have one patient right now who's just like, I'm gonna give it a try. And you know what? We're gonna support him all we can, because who knows, right? Like you never know. It really seems to be like who you get on the other end of the line. So we tell patients, if you call Cigna and they give you a hard no, and you tell them that you have a durable medical device that you have a prescription from your doctor for, and they say no, then you call back, and just call back until you can get somebody who can give you an answer. So anyway, the bottom line is we're getting more and more patients that are reimbursed, and we do give them everything they need to submit a claim. Next slide. And again, I went through the steps. We are a licensed DME provider. We are the only licensed DME provider for the Home 2 in the United States. We also just got approved through United Healthcare as a registered provider through them. So again, kind of baby steps, but there are more and more patients that are getting reimbursed, and it's really exciting because I think we all can look at it and say, if we knew insurance paid for this, 80% of patients with glaucoma would have this device in their house. So pricing, quickly, the diagnose is $249 for a 1 weekly rental, and then $149 for each additional week. We now have an aftercare plan, which is really exciting. And that was at the request of our physicians who want to monitor patients throughout procedure. So it's a monthly subscription that's $299 a month, a minimum of 3 months. So you can use it before, during, and after surgery or any type of procedure, and the patient can keep it in their home for that time. The purchase includes everything the patient needs to get them going. Warranties are available, and that's $29.99. And I just wanted to point out and introduce Ashley. She's our Vice President of Medical Relations for those physicians on this call. If you have any questions, feel free to reach out to Ashley, and she will get with you if you want patient cards. Anything you need, a lunch and learn, we're happy to do any of those things for you and your staff. But she can, again, put you in touch with people that you need to, or just be able to reach out to your team. And I think we do have a question here.
We do. Thank you so much, Erica. Thank you. I hope everybody found this informative. So there's a question from Dr. Hesseltine, and it says, are there drug strategies you use to manage early AM spikes, specific drugs, dosing strategies? So interestingly enough, and again, this is, anecdotal experience, we're trying to figure more and more about this. But yes, there are certain drugs that seem to be much more effective at the early waking hours. And interestingly enough, it is exactly what the Rojas paper published, which was with notarsadil. So a lot of times if I'm trying to lower those AM spikes, I will change a patient from latanoprost to rocklatan. And I find that that has worked. The other thing that tends to really flatten the spikes, and we've presented this data, and we will be publishing it, is we looked at SLT, but those were in less severe patients. And we did find that SLT actually does decrease those spikes. And again, that was the example I had with my patient. If you're familiar with the LIGHT study, so that looked at SLT over time in terms of what it did to not only looking at, it was a study out of Moorfields, and they asked the question, how does SLT perform versus topical IOP lowering drops in early patients, treatment naive patients? And SLT worked as well as the topical eye drops, but over 6 years, they found that patients had less progression on visual fields. So we suspected that maybe it was because of flattening of those variability on the spiking. And we did find that our patients at Moran that received an SLT, it did flatten those spikes. So that was work that we did at Moran and published. We will be publishing that, but we've presented it. So to answer your question, yes, certain drugs do work better. But again, it's an evolving space. And this is where the data coming out from Moran and Wilmer will be really helpful. Also with surgeries, why does Hydrus, it's interesting, you look at the Horizon paper from Hydrus and, you find that over time, they actually reported less visual field loss. And there you always have, IOPs that are on average in the mid-teens, and again, maybe there's something to that distal resistance as well. So, but we're learning which therapies work best. PreserFlow, that completely flattens the curve, completely flattens. It straight lines it for my patients, and I'll send them up to Canada under IGOMHED to get the PreserFlow.
Thank
But
you
it's
very
probably
much.
because you're bypassing the outflow system entirely. So the same as a trab. Any other questions? Well, thank you very much. I don't know, I see Yan went off mute. Did you have a question? Well, if there's no questions, thank you very much for listening. I hope this was helpful. I hope it gives you some examples of why I've become so passionate. And as Erica alluded to, it really is a grassroots effort. It is our colleagues across the country meeting with AAO, meeting with AGS, meeting with CMS, meeting with insurance companies to try to get this accepted as standard of care, because I think it really will help us to diagnose and treat earlier rather than waiting for damage to occur. So with that, I will close out the meeting. Thank you, everyone. Thanks, Choa.
Thanks, Dr. Wirostko.
Thanks. Good night, everyone.
Good night.